Thank you so much. Well, okay. I'm Margherita Zanoni. Thank you very much, everyone, for being here today. Nick introduced me. I'm a PhD candidate at Cambridge University. I work with Orchard OCD, and I'm very proud of this. And I'm also a person with lived experience of OCD. And definitely my lived experience of OCD influenced my professional life, as you can see. So what I'm going to present you today is the state of the art about what we know about the relationship between trauma and obsessive compulsive disorder and why this is important. What we are doing at Cambridge University as part of my PhD in order to better understand this relationship, and what we plan to do in the near future. So in order to start this talk, I have to go back to 2020, 2021, during my time at University College London, during which I developed a very strong interest in mental imagery, and especially in intrusive mental imagery in the context of OCD. And this interest stemmed from the fact that when talking about OCD, I heard many clinicians and researchers mainly talking about intrusive thoughts, but this was somehow out of tune with what I was experiencing, with my lived experience of OCD, which was characterized by horrific intrusive images. And I also knew that to be the case for many other patients with OCD that I met throughout my recovery journey. And studying the condition, being in the field of psychology, I also knew that according to the Diagnostic and Statistical Manual of Mental Disorders, intrusive images constitute a diagnostic criterion actually for OCD. So I really couldn't completely understand why intrusive images were so neglected compared to intrusive thoughts. And I started to wonder whether actually intrusive images might somehow differ in their cognitive correlates and also not biological, but neurocorrelates, could be different somehow from intrusive thoughts. Because in my lived experience, again, the ERP didn't work as effectively on intrusive images as it worked on intrusive thoughts. So basically, I embarked on this project with my back then supervisor, Dr. James Bisbee, as well as our colleagues from UCL and more recently Cambridge. And this work became my MSc dissertation. This is now a paper under review for publication. Hopefully this will happen soon. And I decided I would basically conduct a systematic review of all the literature we had so far about the role of intrusive imagery, both in the psychopathology and treatment of OCD. And it was while conducting this work that I came across some very interesting data that went even beyond the intrusive imagery in OCD, and that was what actually paved the way for what I'm studying now during my PhD. So I'm now going to show you some very interesting data, in my opinion, that are at the basis of what I'm doing at Cambridge University at the moment, and are data who are very interesting in order to better understand this relationship between trauma and OCD. The first data I wish to mention is that up to 81% of individuals with OCD experiences intrusive images. And among these 81%, 70 to 79% report that the content of their intrusive images is either directly reflective of, or at least partially associated with, a traumatic memory. The second data is that patients experiencing trauma-related obsessions, patients with OCD experiencing trauma-related obsessions, report their intrusive images as being extremely distressing, very vivid, and feeling as if they were happening in the here and now, which highlights a striking similarity with what happened with intrusive memories in post-traumatic stress disorder, which we also know as PTSD. Now, what is PTSD? PTSD is defined as a psychiatric disorder that can develop after exposure to actual threat and death, serious injuries, sexual or physical abuse, as well as emotional abuse or neglect. And is mainly characterized, not only, but mainly characterized by intrusive memories. And basically, the literature shows us that patients with OCD reporting trauma-related intrusive images seem to experience something extremely similar to PTSD. People with PTSD, when they experience those intrusive images, they feel like they are re-experiencing that event in that precise moment. And these happens, although not identically, but something very similar seems to happen in people with OCD who have trauma-related intrusive images, with the difference that while in PTSD, people re-experience the intrusive images actually reflect something that actually happened to them. In OCD, people will have intrusive images that has some element of the trauma they've experienced, but then the brain makes the rest. Basically, it makes up imagined scenarios which are thematically related to the traumatic event they've experienced. Another interesting data is that individuals suffering from OCD and comorbid PTSD demonstrate worse outcomes following first-line treatments for OCD than OCD patients without a traumatic history. However, there's also very, I would say, pretty good evidence, at the preliminary but quite solid evidence, that these patients do respond well to treatments that address the traumatic component of their OCD. So treatments like imagery scripting, EMDR, which I'm not going into the detail of this, but they are treatments who are usually used to treat PTSD. And there has been a few studies, again, preliminary studies. One was conducted by David Veal, who will talk later on about diet and OCD, where these patients who didn't respond to any cycle of ERP and not even any SSRIs actually responded to imagery scripting or EMDR. And then after having undergone this kind of therapy, they managed to respond better to treatment addressing OCD because their traumatic memories had been addressed. And lastly, the fourth data I want to mention here is that in patients presenting OCD and comorbid PTSD, a decrease in OCD symptoms obtained through therapy seem to correspond to an increase in PTSD symptomatology and vice versa. Now, this data has just been shown by one study, so we should take it with great caution, right? But I thought it was interesting to mention it because, to me, it kind of suggests, speculatively speaking, a dynamic, speculatively speaking for now, like we hope to show something more, seems to suggest a dynamic relationship potentially between the two conditions, between PTSD and OCD in patients who have both conditions. Sorry, I'm Italian, like I sometimes get English wrong. Okay, so obviously, in light of these data, we should ask ourselves whether there should be a trauma-based model of OCD. So one of the questions which is really guiding my studies is OCD that stems from trauma or has a strong traumatic component somehow different, or should it be treated differently from OCD that, to say, stem primarily from genetics or biology? That hasn't been influenced by traumatic experiences? Like, are they exactly the same thing, or are there like any differences that we should take into account in order, obviously, why this would be useful, like in order to have interventions that are tailored to the specific needs of each patient? And we go back to the precision psychiatry Nick mentioned before the break. Now, this image is quite complex, I'm aware of it. I will not go into the details of it. This is just to show the complexity of something we are doing. Basically, to better understand the complex relationship between trauma and OCD, within my PhD studies, we are currently conducting what we call a grounded theory study, okay? A grounded theory study with the goal of laying the groundwork for a model that explains how trauma contributes to the onset and maintenance of OCD. Now, what is grounded study? Grounded theory. Grounded theory is widely recognized as the gold standard methodology, basically, of qualitative research to develop new models, new theories. And the reason why we've decided to adopt this methodology to run this third study of my PhD is that I like hypothesis-driven research where we test hypotheses that we formulate in advance. Grounded theory allows us to take an exploratory approach to the phenomenon we are studying. And the way we do that is that we run semi-structured interviews with patients. Well, before the semi-structured interviews, actually, they are administered like different psychological measures to measure their OCD and their level of trauma. And if they are eligible for the study, the second phase of the study is actually intensively interviewing them. Intensive interviewing means an interview that really goes in depth of the experience of OCD and trauma of that single person. So because this is qualitative research, we are not that much focused on population representativeness. We are actually interested about going in depth in every single person's experiences, and these are obviously people with lived experience of OCD and trauma. So the groundwork that we are developing will be a groundwork rooted in the lived experience of people we are interviewing, and basically grounded theory requires us to carefully analyze every single interviews we conduct with these patients, and every single patient, the experience of every single patient actually is a puzzle piece of what will become our model, basically, or at least the basis of our model. Now, well, the grounded theory study is now ongoing, is currently ongoing. And this study I'm going to introduce you to is actually, I've just started writing the protocol for this. But I believe that the basis on which it builds up are extremely interesting, and I would like to introduce you to some research that indeed form the basis of the second study of my PhD. Basically, what I'm talking about is what is renowned in the PTSD field as the Tetris intervention. The Tetris intervention was born in 2009 in Oxford University within Professor Emily Holmes' lab. And it was born to be applied on people who had experienced potentially traumatic events and who experienced traumatic memories following those events. So the way the Tetris intervention works is strikingly simple in a way, but still grounded in pretty solid science. Basically, Tetris is a visual spatial game, so it's a game that heavily involves your visual spatial working memory if you perform it. And basically, researchers have found out that if you engage in a specific version of Tetris that they have designed, soon after recalling a traumatic memory, that memory is somehow disrupted. The brain will store it in a different way, and it will not be as intrusive as it had been until that point. Now, the mechanisms behind the Tetris intervention, so why it works, so I'll show you some data that really seems to work, is still to be clarified. But there seems to be a sort of competition between the traumatic memory and what we need to play Tetris, because it seems that the brain areas involved in forming traumatic memories are the same brain areas that are involved when we play Tetris. And because our working memory has a limited capacity, the two elements will basically start to compete if we do this at the same time. And if we stick to the Tetris intervention, that basically takes over in our brain. That's very simply put. Okay, researchers from Professor Hamley Holmes' team first tested the principle behind the Tetris intervention in controlled laboratory settings, right? Because that's what we do when we test new interventions. We go and test them in controlled laboratory settings first, and then if they show a certain degree of effectiveness, then we test them on the clinical population of interest. And basically, what they did for the first time they tested this intervention in this control setting is that they showed their participants what we could define like trauma analogs that were basically video clips of severe injuries, car crashes, abuse for 12 minutes. Then they made them wait for 30 minutes and then divided their participants in two groups. One group had to play the version of Tetris they had designed for 10 minutes, and the other group didn't have to do anything. For the following week, all participants were required to keep track in a structured diary they were given by the researcher. They were asked to keep track of all the intrusive memories they would experience about the video clips they had watched. What happened is that the half of the group who underwent the Tetris intervention experienced about 3 times fewer intrusive memories compared to the half of the group that didn't play. And importantly, the overall memory of the people who had played Tetris remained absolutely intact, so they remember very well what they had watched. But the intrusive, distressing visual aspects of the memory was significantly decreased compared to those who hadn't played Tetris. Then in 2017, there was enough evidence coming from the laboratory settings suggesting that the effectiveness and safety, very importantly, of the Tetris intervention, that researchers began to test it on the PTSD population. The PTSD population was their original population of interest. So for the first time on a clinical population. So the first study they conducted, this is from Horsch and colleagues, 2017, and they basically conducted on women who had to undergo an emergency cesarean section due to threat of death to either themselves or their babies. So in this case, the Tetris intervention was tested very much as a preventative intervention, right? Because these women didn't have a diagnosis of PTSD before the emergency C-section, but potentially they could have been traumatized by what they were going through, threat of death to either themselves or their babies. And here, again, as you can see, the women who performed the Tetris intervention, what happened? Sorry, I was missing a quite important part. Within 6 hours after the emergency C-sections, half of these women were given the Tetris intervention, and the other half was not, because they had to function as the control group of the study to see if actually the intervention would work. And the half of the women who underwent the Tetris intervention actually showed up to 50% less intrusive memories of that traumatic event compared to the women who didn't undergo the Tetris intervention. In 2022, these results were replicated and extended by Deforge and colleagues, who this time tested the Tetris effectiveness in treating already consolidated traumatic memories in a group of women who had experienced a traumatic birth between 7 months as many as 7 years earlier, and reported intrusive traumatic memories of that event. So there were women with full-blown symptomatology, potentially PTSD symptomatology. They did exactly the same thing that in the other study, with the difference that they actually followed up these women for up to 1 month. And again, here, as you can see, compared to the beginning, compared to before the Tetris intervention, these were women, again, with full-blown symptomatology of PTSD. After 1 month, they showed that their intrusive memories had decreased by as far as 80% compared to pre-intervention. So, why did I talk about PTSD so far? Why is it important? Very much for the reasons I was mentioning at the beginning. Why Tetris what to test tetris for OCD intrusive images. As I previously mentioned, OCD intrusive images and PTSD intrusive memories share some quite striking, I would say, similarities. And OCD intrusive images are often vivid, repetitive, and extremely distressing, much like trauma-related intrusions in people with OCD. And if it is true, as data shows, that in up to 70% of individuals with OCD who experience trauma-related intrusive images, if it is true that if the data are actually right, this is what I want to say, then if this intervention works for people with intrusive traumatic memory, then it should, we have good reasons to think that it should work for people who have trauma-related OCD intrusive images. And also in those people with OCD with trauma-related intrusive images who don't respond to first-line treatments for OCD, but do respond to treatment addressing the traumatic component of their OCD, we might, again speculatively, because we still have to start running the study, but we might think that administering the tetris intervention to these patients might actually make them more prone to then respond better to intervention specifically for OCD, so ERP, SSRIs, as long as the traumatic component of their OCD is addressed appropriately by something that addresses the traumatic component. And also, this is actually quite ambitious, but yeah, I believe in it. I think that even potentially, even those patients with OCD whose intrusive images don't necessarily stem from traumatic experiences, but they are just a pure result of OCD, I think it could be worth trying to apply this intervention to them as well. Because, as I said earlier, intrusive images in OCD are very vivid, extremely distressing, repetitive, and as all people with lived experience know, they can become traumatic, like they become traumatic. And your brain will store those images and they will become traumatic images per se. So I think it will be worth trying to apply the tetris intervention on these patients as well and see whether they could respond as patients with traumatic memories respond, or at least partially. So in summary, there is a strong link between trauma and OCD. We know that this link exists. We just don't know yet fully the mechanisms underlying this relationship. And this is exactly what we're trying to understand with the grounded theory study, interviewing patients with lived experience and with potentially tetris intervention. We know that there are striking similarities between OCD intrusive images and PTSD intrusive memories, sorry. And therefore, we may be, in the light of the fact that also many patients with OCD with trauma-related intrusive images respond well to therapy for traumatic memories, we should ask ourselves whether maybe a trauma-based model of OCD should exist, and as a consequence, ad hoc interventions for these patients should be developed. And again, we are trying to do that through my PhD, which is still very much in its infancy, but it's progressing. Thank you very much.